oral cancer cases arising every year, and this is Globocan data 2020. So, and of course, there are various reasons and why we are having so big numbers. But today, this domain we are looking at how we can diagnose them early, catch them early, and treat them early. And one of the ways in which we can diagnose them early is by diagnosing lesions which will progress to oral cancer. So if you see on the slides, the first picture, you'll see absolutely no lesion on the tongue. The second has some leukoplakia or white patch on right lateral tongue, which slowly progresses to a full-blown oral carcinoma. And of course, there are some lesions which will directly grow into an oral cancer, but in majority of lesion, it will metamorphose from a leukoplakia to oral cancer. And this is how it goes from normal to premalignant to malignant. And this is how the histopathological picture and clinical picture looks like. And that is the reason why we are discussing today what are oral potentially malignant disorders. So before 2005, they were known as precancerous or pre-malignant lesions, and it was defined as a morphologically altered tissue in oral cancer, in which oral cancer is more likely to be occurring. While in 2005, it got transformed to a better title called oral potentially malignant disorder. And why it is a better title? Because not all pre-cancer, which was previously known as pre-cancer, not all of these lesions, they get transformed to cancer. That is the reason why they are told they are renamed as potentially malignant disorder. So, according to WHO, following are the lesions which were classified as oral potentially malignant disorders. One is leukoplakia, erythroplakia, parietal lesions of reverse cigar smoking, oral lichen planus, oral submucous fibrosis, and lupus erythematosus. This was way back in 2007. Of course, there have been modifications with the evidence coming in. I'll enlighten them with further slides. So, what exactly is a definition of OPMD? So, OPMD is any oral mucosal abnormality that is associated with statistically increased risk of developing oral cancer. To start with, so throughout the talk, I may not be able to cover the entire spectrum of oral potentially malignant disorders. There are 22 of them, but I'll stick on to few common which we see day in and day out in our clinics. First is leukoplakia. It was first used way back in 1877 by Squamous to denote any white lesion of the oral cavity. And this is the most common precancerous lesion of the oral mucosa, or to be precise, most common oral potentially malignant disorder. And it is defined as a predominantly white lesion of oral mucosa that cannot be characterized as any other definable lesion. So it's a diagnosis of exclusion. You need to exclude all other lesions which are not leukoplakia and then come to conclusion of leukoplakia. Therefore, it's a diagnosis of exclusion. Now, when you want to make a clinical diagnosis of a leukoplakia, what you need to see is whether the lesion has well demarcated borders, whether the lesion has any red or nodular component to it, whether there is any associated sharp tooth or ill-fitting dentures in congruence or in association, in proximity of the lesion, and whether the lesion is not reversible, and whether the lesion does not disappear or fade away on stretching. So all these are clinical signs which will help you diagnose leukoplakia. Now let's come on to the epidemiology. What is an incidence of leukoplakia? So incidence of leukoplakia is 2%, but in India it ranges from 0.2% in Bihar to 4.9% in Andhra Pradesh. And recent studies in Gujarat have shown it to be as high as 11.7%. And male to female ratio is 3:1, but obvious because of the use of tobacco. Now, what are the reasons? What are the etiology? So, majority of the etiology which we could find out is tobacco. It has 6 times more higher chances of person having leukoplakia as compared to those who do not have. Second is arecanut. Third is alcohol. So 1, 2, and 3 are class 1 carcinogen, and that is the reason why we are extrapolating data that these might be the factors responsible for causation of leukoplakia or oral potential malignant disorders. But 4 and 5, that is chronic mucosal trauma and poor oral hygiene, we have our own studies and review of literature which supports the thought that they are contributory factors. They may not be the etiological factors, but they are contributory factors. So let's first classify leukoplakia. So leukoplakia can be classified into homogeneous leukoplakia and non-homogeneous. So as the title suggests, homogeneous means uniform, predominantly white lesion with uniform flat thin appearance, while non-homogeneous leukoplakia means there is some red component to it, which is further subclassified into ulcerated, nodular, and verrucous leukoplakia. So if you see the first picture, it's more of a uniform white patch with pebbled. So it has been described in the literature as a pebbled appearance. While if you see the second picture, it is more of a nodular. Now, what is the difference between these? The first is it is a homogeneous. Second is non-homogeneous, and nodular part of non-homogeneous. The most important part of any leukoplakia or any oral potentially malignant disorder is what is its potential to transform to cancer. So if it is a leukoplakia is less homogeneous leukoplakia, it is less than 1%. But if it is nodular or non-homogeneous leukoplakia, it is upwards of 5%. So it is a difference, and it is the most important point we always look out for, and why we are differentiating into homogeneous and non-homogeneous. Just to show you what kind of ulcerated leukoplakia looks like, the upper picture is on right commissure and buccal mucosa, who is a BD smoker, while the lower picture is a nodular leukoplakia on left buccal mucosa. Similarly, verrucous type of leukoplakia, these leukoplakias are plaque-like, they are thick. Of course, they might be more of white with no red component to it, but they are thick and plaque-like a lesion, maybe on the palate as in the upper photograph, while on the tongue in the lower photograph. Now, this is a kind of a leukoplakia which is very important to us because it has a very high malignant transformation rates. So proliferative verrucous leukoplakia, as you see in the photographs at different sites, it has a very high malignant transformation rate, as high as 63% documented in literature, and it is preponderant more in elderly females with no tobacco habits. So that is the reason why this leukoplakia captures a specific place in our mind as far as diagnosis of leukoplakia is concerned, because it has higher chances of conversion to cancer. Now, just to give you a clinical difference of proliferative verrucous leukoplakia and a leukoplakia, in leukoplakia are mostly in men, while PVL, that is proliferative leukoplakia, are mostly in women. PVL does not have a strong association with tobacco use, while leukoplakia has. Proliferative leukoplakia is not single foci. You will have it will be like a complete field canceration, bigger diseases covering multiple sites in the oral cavity, while leukoplakia, single leukoplakia will have single site, maybe at buccal mucosa, especially in Indians, while on lateral part of tongue in Western population. You will have more of dysplasias in leukoplakia, but in proliferative leukoplakia is less than 10%. But the malignant transformation rates is very high in PVL as compared to leukoplakia. And you see the second last line, 10% of all the proliferative leukoplakia, they convert to cancer every year. That is a very important statement which we want to make. So whenever you come across such lesion, please keep them under regular follow-up after biopsy. And as leukoplakia are of single foci at single site, they're easily accessible, while the proliferative leukoplakia might be difficult to treat because even the excision will involve bigger removal or excision of mucosa. So as I've already seen, there are the various phases. One is homogeneous, white translucent plaques. Second is thick homogeneous plaque, third is nodular and granular, and fourth is erythroplakia. It is not necessary that the lesion will follow these phases, but usually how it goes. So why is leukopenia so important to us if only 1 or 5% of them may be converted to carcinogenesis? Because what happens is, even there are national and international studies which says that any leukoplakia or any potentially malignant disorder will remain the same in 80% of the cases. It will regress only in 11% and 3.3% in Indian and international studies respectively. It will stay the same in 50% of the times, while it will progress in 30%. So it might not transform to malignancy, but it progresses in 30% of all the cases. So when we see any oral potentially malignant disorder, or especially leukoplakia, what are the red flags we want to be attached to? We need to know in our mind that yes, this is the lesion which we need to keep it under regular follow-up, under regular surveillance, or there's a need of a biopsy. First is female gender with no tobacco habits. So if there is a lesion in female with no tobacco habits, then it is a high risk for malignant transformation. Any leukoplakia which is there in the mouth for more than 5 years, leukoplakia in non-smokers, high risk site like tongue and floor of the mouth, when the size of the lesion is more than 2 by 2 centimeters, when it is non-homogeneous type, and if you have taken a biopsy and there is a presence of dysplasia. So all these risk factors, all these are high risk factors for its malignant transformation. That is the reason why you need these lesions which have these factors to be kept under regular surveillance, and if need, do a biopsy. So the second most common, I would say, lesion which we come across is an erythroplakia. So how is erythroplakia different from leukoplakia? Erythro is red, plakia is plaque. So it is a fiery red patch of bright red that cannot be clinically again characterized as any other definable lesion. So what are the different conditions which you first rule out before diagnosing erythroplakia? Is it is a non-homogeneous leukoplakia, erosive lichen planus, acute atrophic candidiasis, invasive oral cancer, pemphigus, lupus erythematosus, hemangioma, and denture-induced stomatitis. Why we need to differentiate the erythroplakia from these lesions is because they have different malignant transformation rates. For example, oral cancer is a full-blown oral cancer, while others like non-homogeneous and oral erosive lichen planus have lower malignant transformation rate as compared to erythroplakia. So this is just an example of how it looks on the right buccal mucosa. You can see the stained teeth indicating the use of tobacco. This is again another leukoplakia case, again up in the upper. Almost it looks like a full-blown oral cancer. Now, why it is called dangerous mucosa? It is called dangerous mucosa because according to an Waldron study, it says that 80% of these erythroplakias may contain some areas of microinvasive cancer at the time of initial biopsy. That means they are almost malignant. It may not be carcinoma in situ, but you should always keep such lesion under your surveillance, maybe excise it and send it for histopathological reporting to get the complete diagnosis. So how do you manage? Is first you advise any individual or patient who is having a leukoplakia or erythroplakia to stop any instigating factors which we have already shown you in the previous slides. They should be encouraged to eat diet-rich vegetables and fruits. In view of high malignant potential, lesions are recommended to be excised, which can be done either by laser or cautery or knife. Chances of recurrence and development are different in different lesions, and that is the reason why, especially in erythroplakia, when the recurrence rate and the malignant transformation rate is high, they need to keep under more close surveillance. The next lesion which I want to touch upon is oral lichen planus. Oral lichen planus is a chronic cell-mediated immune disorder that can affect oral mucosa, skin, genital mucosa, scalp, and nails. It is an autocytotoxic T lymphocyte trigger apoptosis of epithelial cells, and stress is one of the most frequent causes of acute exacerbation of these lesions. So, just to give you a clinical description on how it looks, it has white striations. Now, if you see in the upper right photograph, there are many white striations with normal mucosa in between. These striations are called Wickham's striae. They are usually present on both sides of the oral cavity and especially on buccal mucosa. And they are in literature, they are classified in 6 types: reticular, annular, papular, plaque-like, erosive, atrophic, and bullous. And the 2 major clinical forms are reticular and erosive. So, just to give you another information on which lesion you should be very susceptible, or I would say a very sensitive of, is erosive type of oral lichen planus, because it has higher malignant transformation rates. So, in recent meta-analysis published in 2020, which says that there is still no consensus whether the patients of oral lichen planus have increased risk of developing oral squamous cell carcinoma. The reported annual malignant transformation rate is usually less than 1%. And that is the reason why there are chances of maybe in the future OLP may be removed or excluded from oral potentially malignant disorders. For now, it stays. The next, I would say, condition. So previously, oral submucous fibrosis was a condition when before 2005, when the entire lesion was classified into premalignant lesion and premalignant condition, but now they are clubbed under oral potentially malignant disorders. OSMF is characterized by unique generalized fibrosis of submucosa of oral soft tissue, resulting in marked rigidity of oral mucosa. And oral submucous fibrosis is mainly influenced by the consumption of areca nut supari. So if you see the market of production of areca nut all over the world, and if you map it, that will be the exactly maps and countries of the areas of the countries which will have higher incidence of oral submucous fibrosis. Such is an impact of areca nut on oral submucous fibrosis. And in this disease, there is a progressive inability to open the mouth, rigidity of lips, and difficulty in protruding the tongue. Prevalence of OSMF ranges from 0.2 to 1.2% in India. Now, why it is such a difficult lesion to treat or disorder to treat is because it is irreversible. Once the patient's mouth closes, it never opens again until and unless it is surgically treated. So it did not regress either spontaneously or with cessation of betel quid and elimination of other presumed risk factors. And such patients usually experience burning sensation and they have problems with having spicy food. So there is initially there is increased salivation, then which is followed by diminished salivation. So as the disease progresses, there is restricted patient's ability to open the mouth. There is altered taste, difficulty in swallowing, and sometimes partial hearing loss. OSMF is classified histopathologically and clinically. This slide gives you more of a clinical picture where the classification is based on the interincisal mouth opening. Stage 1, stage 2, stage 3, and stage 4 are according to the mouth opening ranging from 35 millimeters to less than 15 millimeters. And the most important point again, which I want to highlight, is what is its malignant transformation rate. So malignant transformation rate of oral submucous fibrosis is 0.1 to 7.6%. Again, that is significant. And that is the reason why it not only, so if you see leukoplakia and erythroplakia, they inherently do not cause problems for you. It is just that they have a malignant transformation rate, has a potential to turn malignant maybe in the future. But oral submucous fibrosis in itself is a disease. It restricts your functional ability to eat, to talk, to speak, while it also has a malignant transformation rate of up to 7.6%. So, if you ask me to talk on oral submucous fibrosis and its management, I can go on for hours. But since we don't have that much time, we'll just stick on to the few bullet points on how we can tackle such disease. Is first, of course, is cessation of habit, correction of nutritional deficiency, if any, especially such people have iron deficiency, mouth opening exercises with the help of a physiotherapist, oral lycopene, and submucosal injection of steroid and hyaluronidase, collagenase, and pacifical extracts in stage 1 or stage 2. And in grade 3 and grade 4, you should always counsel the patient or at least give the option of surgical treatment or removal of fibrous tissues and using some kind of a graft which are not subjected to tobacco, like you can use nasal flap or free radial artery forearm free flap. So again, there are studies from Tata Memorial Hospital which says that the oral cancer which arises from OSMF, they have done studies especially in these oral cancer compared with those lesions which do not have oral submucous fibrosis in background. So when they compared these two lesions, what they found was patients of oral cancer with OSMF, they are younger males with better prognostic factors such as better tumor differentiation, lesser incidence of nodal metastasis, and extracapsular spread. That does not mean that you should consume areca nut and have OSMF and then oral cancer. Absolutely not. It's just a comparison between these two lesions, and if so that you can prognosticate such lesions in a way when the patient has both of these. This is another topic which I want to touch upon is visual screening. Earlier in the introduction by Dr. Sudhir, he said that screening is also a very important part of oral potentially malignant disorder because we are very fortunate that these lesions can be easily seen by the naked eye under bright light. If these lesions were present in the stomach or it were present in colon, you need endoscopy just for its visualization. So in our situation, when such lesions are directly seen in the oral cavity, it becomes very easy for us to diagnose these lesions in early stages or even in the pre-malignant stages. So why are visual screening for oral cavity an impactful or an effective way? Because they are surface cancers, they are amenable to examination, they are accurate, they are safe, it is non-interventional, and it is cost effective. So just to give you a magnitude of impact the screening has, there was a paper long back, 17 years back by Shankar Narayanan, which studied the effect of screening on oral cancer mortality in 4 districts of Kerala in a randomized controlled trial in a lakh in a participants to the scale of 1 lakh participants who were included in this study, and it said that if high risk individuals consuming tobacco are screened effectively, are screened systematically, then the oral visual screening itself can reduce the mortality in high risk individuals to the potential of preventing 37,000 oral cancer deaths worldwide. And for this, you do not need any CT scan, MRI, or scope lesion, etc. You just need light and your knowledgeable eye. So when I say knowledgeable eye, if you have a knowledgeable eye, and even if you are not I would say not a medico, you can still be very vigilant enough to diagnose such lesions. So this is not what I am telling you. It's a study which has been done in oral oncology, which says that as breast cancers, the breast self-examination has made a significant impact on early diagnosis of breast cancer. Similar impact can be created even in oral cavity cancers because surface cancers. And it says that if the awareness program is done in high-risk individuals, then the compliance rate for mouth self-examination to the scale of 87%. And the detection rate of oral cancer is compared to the trained healthcare workers. Specificity is high, positive predictive value is high, but sensitivity is low because of the lower awareness. So if you make the patient, or if you make your high risk individuals who is consuming tobacco aware on where you need to see the lesion, then definitely it would at least motivate him to get it counseled or get it checked by a qualified doctor. So next, after screening, what we come on to is what a doctor can do in addition to the bright light and his knowledgeable eye. What other diagnostic adjuncts he can use. So they are basically classified into 4 types: supravital staining, brush cytology, optical imaging system, and salivary diagnostics. We go to staining techniques, and one of them is Tulurin blue. It's a vital stain that binds to DNA. If you see the lower photograph, here the Tulurin blue is specifically stained at certain areas of the leukoplakia lesion, and dysplastic and malignant cells have high nucleic acid content. But what is the problem of such test? These tests are not usually used. And what is the reason? Reason is it also stains any areas of ulceration and inflammation, even if it does not have malignancy in them. So it has a high false positive. 30% are false positive. They are stained even in benign lesion. One of the ways in which you can surpass this false positivity is to stain them twice. You stain them once, you call them again in 2 weeks, give them anti-inflammatory, and then again stain them, and then you compare the photograph. But again, you need to have proper documentation and check between the first and second photograph. And this is the personal experience. There's no study to say that this kind of modus operandi helps. Next is brush cytology. It was introduced as a potential oral cancer case finding device in 1999. And the whole concept lies that the cohesion of these cells in the oral cancer is decreased, and that is the reason why that leads to shedding of cells. And these cells then can be studied under microscope to check for any malignancy. But again, the problem lies if you are using brush cytology for oral potentially malignant disorders, the cohesion is reduced in oral cancer and not in oral potentially malignant disorders. And that is the reason why you will not have such cells on the surface for brush cytology to be effective enough. So if you see, they have good specificity and high sensitivity rates, but these rates are high in frank oral carcinomas and not in premalignant lesions. The next type of adjunct which are described in literature is chemiluminescence, where a chemical like acetic acid is painted on the lesion and they are seen under blue light. If it is opaque, then it has higher chances of harboring malignancy. Again, there are not much studies to compare these with the usual biopsies, and even if it has some kind of adjunctive aid to diagnosis, but there are few drawbacks. So, for example, in chemiluminescence, it fails to spot red patches, and as shown in the previous slides, that red patches are more important patches because they have higher malignant transformation rates. The next is narrow band imaging, and we have used this tool even in Tata Memorial Hospital, and we have studies, retrospective studies to support it. So basically, it's a concept in which any cancer drives vascularity. So cancer will have a lot of vascularity around it, and when there is carcinogenesis, there will be more microvasculature around that lesion. And based on this concept, narrowband imaging helps in catching these neovascularization. And in studies, they have classified these microvascular into loops, microvascular structures or architecture into loops called intrapapillary capillary loops. So if you see type 1, and if you see a small box in the type 1, there are usual U-shaped vessels. They're type 1, they're normal mucosa. In type 2, they are more of similar kind of a comma-shaped microvascular, but the caliber is high. In type 3, it is more of an tangled lines with increased length of the vessels. And in type 4, that there are no loops. So studies have shown that type 1 and type 2 are, I would say, non-suspicious, but type 3 and type 4 are more of a suspicious lesion in the oral cavity. And studies have shown that sensory specificity to diagnose an oral carcinoma is to the scale of 84 and 94% respectively. But again, whether it works in oral potentially malignant disorder is questionable. And this is a Cochrane review which was published in 2013, and it says that the evidence is limited to few studies. The randomized controlled trials are awaited. There is no evidence to support the use of adjunctive technologies, including fluorescent blue, breast cytology, fluorescence imaging as a screening tool to reduce oral cancer mortality. They might have potential, but whether they can be utilized in real world setting is still questionable. Just to give you a broad on how we stage leukoplakia, like in oral cancer, we stage as T and M. Here we stage as L and P. L is again like a T size of the leukoplakia lesion, less than 2 centimeter, between 2 and 4, and greater than 4 centimeters. While P is presence of dysplasia. So presence of dysplasia is very important factor to understand the malignant transformation rate in that particular lesion. That is the reason why presence of dysplasia directly categorizes the leukoplakia into stage 3 and stage 4. So just to give you a broad view on management of leukoplakia is, first you do a biopsy. In a biopsy, if it is non-dysplastic, you observe if it is if there is some keratosis involved, like if the report comes as hyperkeratosis, then it is important to classify into large and small size. If it is a large size lesion, you take a biopsy. If it is no dysplasia, you again follow the patient every 3 months and again take a biopsy annually. But if it is small lesion, less than 2 centimeters or 3 centimeters, you excise it with proper 2 to 3 millimeter margin and follow them up every 6 months. But if there is a dysplasia component, moderate or a severe dysplasia, then definitely you need to excise with margin, send for frozen section, and check if the lesion has any kind of foci of oral carcinomas. So just for the sake of completion, I'll just touch upon the other oral potentially not so common malignant disorders. First is nicotinous stomatitis, which is not an oral potentially malignant disorder, but I've included this in a slide because I wanted you to differentiate it from a reverse smoker's palate or nicotina palatini. So nicotinous stomatitis is not an oral potentially malignant disorder, while reverse smoker's palate or nicotina palatini is a potentially malignant disorder because it has high melanin transformation rate, seen especially in people who use cigarettes in a reverse way. Again, tobacco pouch keratosis was not classified as oral potentially malignant disorder, but now we have a consensus statement in 2020 led by Dr. Saman, which says that tobacco pouch keratosis, if it does not reverses in 6 weeks, then it might be classified as oral potentially malignant disorder. There are certain disorders, hereditary disorders or syndromes, which have susceptibility of developing oral potentially malignant disorders, like dyskeratosis congenita, epidermolysis bullosa, xeroderma pigmentosum, and Fanconi's anemia. And also graft versus host disease, and especially now when we are dealing with cancer patients, we also have references, or we also have hematologists who come to us and say we have these kind of lesions develop in oral cavity, especially in chronic graft versus host disease. And in one of the studies where there were more than 17,000 such kind of patients studied, and it says that they have relative risk of 2.9 for oral cancers, especially in graft versus host disease. And that is the reason why we need to be well aware of such conditions. Previously classified as OPMD, but now again with the consensus statement 2020 by Dr. Varna Kalasurya, disorders with limited epidemiological evidence. So the evidence are limited to say that oral epidermolysis bullosa is an oral potentially malignant disorder, while previously classified as oral potentially malignant disorder, chronic hyperplastic candidiasis is still insufficient, has insufficient epidemiological evidence of melanin potential. So with this, I come to end of my presentation, where I have tried to cover, I have tried to show the clinical photographs of clinically how leukoplakia, erythroplakia, oral submucous fibrosis, oral lichen planus, they are the common oral potential malignant disorders which we come across. How do you screen them? What are the diagnostic adjunctive aids? What are its malignant potential? How do you manage them? When do you observe them? When do you biopsy them? What are the different red flags which you see in leukoplakia, which have high risk factor for melanin transformation rates, and that is the reason why you need to biopsy them. But there are certain points which are very important to us, which might have a significant impact in future, which we are still looking for, is what is the mechanism of action of transformation of such OPMD to oral squamous cell carcinoma. So if we know why they are transforming and then at least stall them, if not remove them, then we might be able to waive off a lot of mortality related to oral cancer. Role of candida in oral carcinogenesis. And as I have shown you previously, specifically on graft versus host disease, where the hypothesis is because of your immune suppression, the development of oral cancer needs to be studied. Whether there is any molecular differences between the leukoplakia with high malignant transformation rates like homogeneous leukoplakia and erythroplakia. There's a need to identify reliable molecular, predictive, and prognostic biomarkers to guide personalized management of OPMD. As a current model to estimate the risk of melanin transformation is based only on clinical and histopathological features of the observed mucosal changes. So with this, I come to end of my presentation. Thank you very much for the opportunity.
Thank you, Hitesh. That was an excellent summary and over that topic, where you were successful in bringing out the most important aspects of a very complex and difficult to explain topic. I think it is very simplified. It's difficult to simplify things. Most complex action is to simplify things. I think you were successful in simplifying the complex aspects. Yeah, I mean, there are a couple of questions which are posted in the chat box. We will discuss those which are relevant for today's topic. I think the first, I think there is somebody is asking about the role of local metronomic chemotherapy in the management of high-risk OPMDs, especially proliferative verrucous leukoplakia. Do you have any idea, or you can talk? And yeah.
So I have not come across any study which show that there is any effect or impact of metronomic chemotherapy. So we have seen, so metronomic chemotherapy works especially in high risk individuals post definite treatment like surgery and radiation. But as far as metronomic chemotherapy is concerned, I don't feel there is any impact of such strategies even on high risk proliferative verrucous leukoplakia. But I feel what the question or Dr. VK Hazare wants to ask is whether there are any ointment or like product like turmeric or product like I would say such things have any impact on proliferative verrucous, and even in those situations we don't have any evidence to support that. Dr. Nair is doing a study on turmeric. So would you like to highlight on that?
Yeah, I think I will comment on that. One is proliferative verrucous leukoplakia. The problem is a lot of times when they do the biopsy, it often comes as erythroplakia or some sort of sometimes the cancer, diagnosing a cancer in that such a lesion is difficult. So sometimes you need to any proliferative verrucous lesion. The best treatment will be excising it and sending the whole specimen for pathological evaluation, because sometimes it can be a well differentiated cancer hiding in that. Now, preoperatively, its pathologists find it very difficult. Now, the metronomic chemotherapy, I think we have given metronomic chemotherapy not for the treatment of leukoplakia, but as post-treatment of cancer. There is one study which was going on as a preventive options to give. There is some studies which are done in the past with using, erlotinib, which is a tyrosine kinase inhibitor, which was given for, it is a EGFR tyrosine kinase inhibitor. Erlotinib was given for treating, it's an oral tablet, and they were tried and showed some promising results, but I don't think it has been became a standard of practice in the clinical trial. Otherwise, we would have used it routinely. Now that is also there, but there are data which has been published also which shows some benefit, but most of the time these are all, sometimes it is called chemo prevention. So in the chemo preventive studies have not completely successful. What happens is when you give the chemo preventive agents, the pre-malignant lesions disappear. Once you remove it, the pre-malignant lesions either reappear, and the risk of developing cancer was persisting. And some of the time, the chemo preventive agents had actually caused some harm to the patient also. So in such situations, these clinical trials have been faulted and could not be taken it forward in the mainstream practice. Now, as you asked for prevention, we have running a clinical trial on second primary tumors, and primarily for prevention of second primary tumors, and second objective is to see how it is reducing the recurrence rate, and that's consisting of giving metformin versus with this thing curcumin, combination of metformin and curcumin. So it is being tried. Now, earlier Selindac was being used and it showed some benefit, but similarly we are trying curcumin plus metformin. It's a combination, and it's a multi-centric study going on. We are looking for, let us see the results of the study, show some benefit in preventing second primary or reducing recurrences. It may be useful, and then probably we can use it in the treatment of these leukoplakia. Now, the second cancer is, how do you deal with multiple OPMDs, field cancerization?
So, very nice question. Very difficult and complex situation we come when we see multiple such oral potential lesion in the oral cavity. So, to simplify it, if it is in continuity, then it needs to be treated as a single lesion. But if it is in different sites of oral cavity, depending on the 7 flags which are shown in the presentation, like if it is not associated with tobacco use, if it is female gender, high risk site more than 2 centimeters, you should undergo a biopsy at different sites and check for the dysplastic content. If it has dysplasia, then you need to excise it, whether it is at 3 different spots. So excision is a must if it has a dysplasia component to it. So all the sites of the OPMD needs to undergo biopsy if these have those 7 red flags.
Yeah. So I think so the author has the person has asked OPMD/field cancerization. I need to clarify that OPMD is different from a field cancerization. Yes. OPMD is as Hitesh mentioned, they are oral pre-malignant lesions or potentially malignant disorders. Now, the field cancerization is one which is genetically altered mucosa surrounding a oral cancer areas, or genetically altered mucosa in the oral cavity, which can be potentially which is developing due to the systematic use of carcinogens for a long period, like tobacco for a long period of time. So that causes field cancerization, and then there can be genetic changes which may not be obvious. Phenotypically they will be normal, but genotypically they are abnormal, and that can lead to high risk of developing cancers in those areas. So these are two different things we need to understand. But so field cancerization is a different problem. OPMD is that's why we are using these chemo prevention studies more and more. We are trying to reduce second primary, because second primary is because of field cancerization. There is a chance of second primary developing in these areas, and So that's the one area we need. Now, another question is the use of tacrolimus 1% cream for erosive oral lichen planus. Is it safe, and any evidence?
So the normal protocol algorithm on how we treat oral lichen planus is first again, you should do a biopsy and check for dysparasitic content. If there is no dysplasia involved in oral lichen planus, then we use antifungals and I would say topical steroids. And the second line of treatment is use of tacrolimus 1%. So there are a few studies. One of the studies in 2017, it states that almost 90% of the oral lichen planus were resolved, but the numbers were very less. The sample size was 20, and out of 20, 18 resolved. So we're still looking at studies with higher sample size and randomized control trial. Tacrolimus has shown some benefits, but then it yet awaits proper evidence-based study.
Thank you. Then evidence-based second line treatment for lichen planus.
Yeah, I think I've covered that in the
Yes.
Yeah.
So then another, I think another question: what are the common causes of PMLs and their prevention? I think you might have already
Correct.
covered that in the topic. Hopefully, that should be clarifying. Now, what are the chances of recurrence of? I think it's off topic, but I have already mentioned that field cancerization. What is field cancerization? Field cancerization develops is because of abnormal mucosa. Abnormal mucosa meaning genetically modified abnormal mucosa because of constant exposure to carcinogens, which are surrounding the developed cancer. So even if you excise a cancer with sufficient margin, there can be genetically modified mucosa close to these areas because of constant exposure, and they are can transform with subsequent continued use of carcinogen or some sort of additional inputs, this thing which can cause transform them, they can develop into cancer. That is one of the reasons for developing the second primary disease. Now recurrences happens because of the most of the time there is the cancer develops in one area, but there can be migration of cells to the surrounding mucosa, which can be smaller amount of cells can be dispersed, like satellite lesions can happen all around the normal. So that is one of the area where when we excise cancer, we need to excise cancer with sufficient margin. So this margin will take care of all these migrating cells, which causes small amount. Whereas in a leukoplakia, the margin may not be that much important. We need to excise the leukoplakic lesions. Whereas in a cancer, we need to take sufficient margin all around of the tumor with sufficient normal mucosa margin. So that should be able to take care of the recurrences. But still, even despite that, recurrences can happen. Second primary can also happen sometimes in the other areas of the oral cavity. So these are areas. That's one of the reasons why after oral cancer treatment also patients are kept under follow-up with the for a long period of time. Now then another question is oral cancer which is not preceded by oral potentially malignant disorders, do they have fatal prognosis? Do you think, Hitesh, any difference between I think the question is, there is a sequential development of cancer that you have a white patch, then it becomes a abnormal potential malignant disorder in carcinoma in situ, then it becomes a invasive carcinoma. Then another thing is you don't see apparently normal mucosa suddenly one day developing an ulcer and coming with that. Is there a difference between these?
Proper longitudinal study to first check upon and follow up 20 years to check upon whether the leukoplakia have been converted into oral cancer. There are not much studies to compare the de novo oral cancer as compared to those lesions which were previously leukoplakia and then convert to oral cancer. Definitely, we can say that if the lesion was previously a leukoplakia, it has taken some time to get transformed to malignancy. Then might hypothesize that such lesion might not be that aggressive as compared to those lesions which have de novo. But again, there's no evidence to support that. What I can say is, as shown by me in my presentation, that if the patient has oral submucous fibrosis, that is one of the oral potential malignant disorders, along with oral cancer, they have better prognostic factors as compared to those oral cancer which do not have oral submucous fibrosis. But this is only related to oral submucous fibrosis. It is a retrospective study, and also they have poor prognostic factor. That does not mean they have poor oral survival. All these factors are yet to be studied. Maybe in future we'll have a study which will compare de novo oral cancer compared to those lesions with leukoplakia convert to oral cancer. We'll have some evidence.
Yeah, so I just add on to that. It's good. I think what Hitesh has almost given the direction. So, sequential development or de novo appearance. I don't think the outcome depends upon the stage. So we can, when you say the statement they have fatal prognosis, is wrong in the sense that all will have good prognosis. They are managed in a proper stage of the disease.
Correct.
So the detection is the key. Early detection of these cancers are the key. And if you detect and treat them, 90% of the oral cancer patients, the early stage cancers, they have a wonderful life and they live without, they have a cure rate. So fatal prognosis is not there, but they definitely, is there a prognosis difference? Can be, as our preliminary studies that Hitesh has published shows that in at least in submucous fibrosis, cancer appearing having a better prognosis compared to other equivalent other type of oral cancer. So prognostically they may have differences. We don't have full evidences to completely state, but definitely, but they all the finally the prognosis depends upon the stage of the disease. So again, once again, highlighting the importance of early detection of these cancers. The next question is, please comment on oral cancer not associated with tobacco use. I think we are deviating to oral cancer, but I think, the last question we can discuss and then we'll find up the session.
So, in one of the red flags which I've shown, especially in those leukoplakias which have high melanin transformation rate, was female gender with no association of tobacco. So that is a high risk for melanin transformation rate. So any lesion in your oral cavity, if you do not consume tobacco, and if you have leukoplakia, then you have higher chances of melanin transformation rate as compared to those individuals who are consuming tobacco. So I can just tell you that 85% of all the head and neck cancers are related to tobacco, but then there are still 15% of them who do not consume any kind of instigating factors like tobacco, alcohol, arecanut, and yet they develop oral cancer. So we are yet to find out the other reasons. One of the reasons we can hypothesize is immune depression, which is shown in graft versus oral disease, where where we see the relative risk of oral cancer is 2.9 times. So in those we hypothesize that your immunity goes down, and that is the reason why you develop such kind of lesions. But these are all hypotheses. We can only prognosticate that if you do not consume tobacco or any instigating factors, there's some instigating factor which you cannot control, which is driving your oral carcinogenesis, and that is the reason why they might be more aggressive.
So I think it is as Hitesh telling, yeah, I mean, so not 95% of our cancers are associated with tobacco. So if we stop tobacco, 90% of the crowd will be reduced in over a period of time. Now, the question is not associated tobacco use. Oral cancer, the other we have already discussed. There may be anemia. It is associated with Fanconi's anemia. It is associated with oral cancer. There can be other features like HPV. But oral cancer per se, HPV association is very, very, very low. We have not seen much of an association. Whereas for oropharyngeal cancers, it is an important association. Then we have recently published from ACTREC. You can also see NAR cancer is published. The title Fusobacterium nucleatum is associated with inflammation and poor survival in early stage HPV negative tongue cancer. So we have identified Fusobacterium nucleatum as a molecular bacterium which is associated with a certain set of tongue cancers. This was recently published in NAR Nature Cancer. So we can refer that publication amid the Dr. Sudhir Nair. So what we can see is they are associated with poorer prognosis. So we don't know, we need to take it further, but fusobacterium is an emerging etiological agent which is associated with lung cancers. We see a lot of patients, young patients who don't have any habits presenting these days with lung cancer. So that is one of the area which we need to explore further. Okay. Thank you so much. I think with this, most of the questions we have answered, and Hitesh, I think contributed excellent today's presentation. In fact, I also picked up a lot, updated my knowledge, and it's very good. And also, I thank DocPlex for giving this platform for today's discussion. Thank you so much. Hitesh, you have anything to comment? Please comment.
Yes, sir. So a few tips will be: early detection is key. Screen your patients, because screening will have significant impact on early detection. And there is no adjunctive aids which will help you. Your knowledgeable eye will be enough with a bright light to diagnose such oral potential imminent disorder.
Thank you. Thank you.
Thank you. Thank you.
Thank you so much. Yeah.
Thank you for that wonderful webinar. It was absolutely wonderful listening to you both here. Very well presented session. A lot of takeaways for the audience. So let's end this session now. So to our dear viewers, thank you so much for attending this session. Do share any more questions if you have. Until we see you again, take care and happy docplexing. Thank you.
Bye-bye.